fantastic opportunities for educational material. And as probably most of you know, our format here is basically short and sweet. So we try to be as informative and as entertaining as possible for half an hour. And today, it will actually be me presenting mainly in 2 papers, but in short, and I will also add another 2 just because of the interest in that field. The topic these days is still COVID-19, so we will still focus on imaging aspects of this pandemic. I welcome Dr. Huang, the first author of the second paper we will discuss later. So she will be available for discussion, and want to thank her very much calling in from Asia, which is of course not easy given the time zone difference. So as usual, I ask all of you to mute yourself, but whenever you want, if there's, especially during the question session, just unmute yourself and speak up. Otherwise, you're always welcome to pose any questions into the chat window. Of course. Okay, so without further ado, let's jump into the first paper. I want to just briefly mention, and by the way, I'm welcoming you from Montreal, as you can see in the background. This is one of the icons of Montreal, the Five Roses factory, but of course that's a virtual background. It's in reality just a few kilometers from here, but anyhow. And the rainbow is actually the Montreal way to address the COVID pandemic. It's everywhere in Montreal. You see that ça va bien aller, or in English, it's all going to be all right. So it's basically the motto of Montreal to deal with that pandemic. Okay, so this paper is has been published recently in the European Heart Journal Cardiovascular Imaging. And it's a paper that is on behalf of the European Association of Cardiovascular Imaging. That's the imaging section of the European Society for Cardiology. And it includes echo, MR, and the other, basically the other cardiac imaging modalities, but mainly echo and MR, at least they are the most vocal in that group. And it is basically a paper that tries to summarize the current evidence and the recommendations on how to deal with COVID-19 and imaging in patients with suspected myocardial injury. And just as a quick entry, we know that about 20% of patients with COVID-19 have myocardial injury. And if you have myocardial injury, that's the bad part. Then the prognosis is going to be bad, and in some series, up to 40, even 50% of those with myocardial injury have a severe course of the disease with a high mortality. So it is important that we are aware of these patients and that we identify myocardial injury early enough. Now, when we look at myocardial injury, and this is something the paper covers, so if I go through that paper, the first figure to me, honestly, Dr. Cosyns actually wanted to make it and then had to drop off last minute. So it's too bad that we don't have him here. If any of the other co-authors is here, happy to have you speak up. So this first figure was, to me, actually a little bit confusing. It was basically the indications. The indications, as I said, are actually much simpler than that here. If you have a patient with clinical evidence for myocardial injury that is based on symptoms like chest pain, shortness of breath, not otherwise explained, arrhythmia, or findings consistent or indicating myocardial injury, such as an increased ST segment or a decreased ST segment. And then you have a positive troponin as the serum marker for myocardial injury, then you know it is myocardial injury. And these patients may have one of two things, mainly. They actually may have more. They may have pulmonary problems with just strain to the right ventricle. They may have just a relative heart failure because of sepsis, so they may be in a septic hyperinflammatory state with a high demand for cardiac output. Cardiac output cannot be delivered even though the heart may work normally. So these are two cases where you have some myocardial injury, but the more severe ones that have a role of themselves, that is two. One is ischemic. We know that COVID-19 also, there's more and more evidence that it acts like an endothelitis. So we have an inflammation of the endothelium that, of course, puts patients at risk for vascular events. So ischemic. And the second one is non-ischemic. And the interesting part, we discussed that a couple of times, and we'll come back to that, the non-ischemic myocardial injury, that often happens in the later phase of the disease. So we have first the viral phase, there's 4 or 5 days, asymptomatic. Then interestingly, it gets contagious, even though the patients may not have symptoms for about 2-3 days. Then 1 to 2 days after becoming symptomatic, it's still highly contagious, and then it drops off. And then you have the pulmonary phase when people get symptomatic, and then you have a kind of a second wave when sometimes people get worse, and then they get into what seemed initially like mostly a respiratory failure, but now we know there's also a lot of heart failure involved in that. So during that second stage, that's where myocardial injury often happens. And here you see in that figure, in figure 2 here, you see, I'll try to zoom that a little bit in. So here you can see that here we're talking about the systemic inflammatory response, the so-called cytokine storm. Especially younger male people are affected by that. Here we're talking about microvascular damage that may already come in early, but mostly happens also here. And this is where it gets really critical, because what may happen here is due to the ACE2 damage, we not only affect things like blood pressure control, but more importantly, ACE2 is involved in regulating the inflammatory response. And if there is damage to the ACE2 receptors, and we know that COVID-19 is caused by coronavirus, and coronavirus enters the system through the cells of the system through the ACE2 receptors. So coronavirus knocks out the ACE2 receptors. ACE2 receptors cannot modulate inflammation anymore. Inflammation is more severe. That's one aspect. The other aspect is maybe even more important. There's also clear evidence that ACE2 is also involved in regulating vascular permeability. So with an ACE2 damage, we have leakage of fluid out of vessels into the tissue. And that is a very important aspect to keep in mind. I'll come back to that later when we discuss the other papers. So that may lead to local edema. So when we talk about myocardial injuries, either ischemic or non-ischemic, ischemic is endothelitis, activation of plaques, ischemic events. That's one. The other one is non-ischemic inflammation. ACE2 plays an important role, and an impact of the microvascular damage is specifically loss of water into the third space. Okay, so then this paper, the key figure of this paper is actually this one, the list of the cardiac imaging modalities, how they compare in patients with suspected myocardial injury. And I don't want to go too much detail. Echocardiography from many centers would be a first go-to imaging modality, and it's a great tool for bedside. It has the advantage that the device can go to the patient, as opposed to CT or MR, where the patient has to go to the device. So there is not the problem of transporting the patient through the hospital. It can look at LV function. It can look at pericardial effusion. It can look at evidence for secondary evidence for myocarditis or pulmonary embolism. The limitations, of course, are that we are not, with echo, we're not that great at characterizing tissue abnormalities, especially inflammation. That's why in myocarditis, you would want to know more about the tissue. And also, if you have a regional wall motion abnormality, it's also not entirely clear is this ischemic or non-ischemic. So echo helps identifying, yes, there is a problem, and may also point to one of the problem, but often it's not definitive. The more definitive are here on the right side. So CCTA stands for CT coronary angiography, and CTT for just a thoracic CT. The thoracic CT is great for the lungs. It is actually more sensitive than the test to verify, and there are multiple examples for that have been reported. Whereas the coronary angiogram is basically only useful for if you really want to target on coronary and there is neither a very low risk, because then you don't need it, or a very high risk, then you also don't need it. Just the intermediate risk patients, those may benefit from a coronary angiography. Whereas if you want to verify lung involvement, then a CT is probably still the tool of choice. When it comes to the heart, however, here CMR has its role. It is here in the recommendations, albeit with a fairly weak recommendation for intermediate probability suspected coronary artery disease, and then especially in myocarditis and also pericarditis. So the advantage of CMR clearly is that it provides the most definitive information on the tissue. In that context, it's very important because it does not only verify myocarditis, but also differentiates ischemic from non-ischemic injury. And if there is non-ischemic, it can then also identify the extent and the pattern of the injury. So this is just this figure is basically the key message of that paper. And in brief summary, echo, very good point of care initial. Let's see what's going on. Then CT coronary angiogram, probably not that big of a role. CT of the chest, very important for the lungs, but does not help a lot with the myocardium. When it comes to the myocardium, and therefore in the context of suspected myocardial injury, I think CMR plays a very important role. And here is the stepwise approach in patients who are suspected to have coronary artery disease. So here's one suggestion from that group, that if there is a low suggestion of that, then there's no exam needed. If it's very high, then go straight to the cath lab. And everything in between, that's where imaging can come in. And in suspected coronary artery disease, it may be a coronary CTA or CMR perfusion plus minus echocardiography. So, of course, as a disclaimer, I'm passionate about cardiac MR, although I'm also involved in CT. So it's not that I'm against CT at all. But in this context where most of the information is in the myocardium, I want to stress the point that with CMR, you can do a perfusion, but at the same time, you can also look at the tissue. So now we're looking at CMR and its role. And here I want to go through some other papers. This is a paper that to me was pretty a little bit shocking because we all knew that the PCR test for COVID was not that great, but that in early stages it is that bad was even to me somewhat surprising. So basically what it says that early after the infection, it really is not very sensitive. So here you see the probability with the test is positive. So it has a good positive predictive value. But here you see the probability if the test is negative, you still have a 10-15% probability. So if you have a patient with a low pretest probability versus a high, that makes a big difference early enough for the post-test probability. So if you have a pretest probability of 44%, so the patient actually, there's a certain likelihood this patient has COVID, you do the test, it's negative, the probability is almost the same. So if the patient does not have a high probability, then it also, after the test, has still not a zero probability. So that's just to show that that the test alone is not that great. So that may be another argument for imaging. Now here's another paper I wanted to briefly mention, published in Radiology Cardiothoracic Imaging. It's actually from Sao Paulo. Brazil is currently very much affected by COVID. And this is just to point out that MR is not only able to do that for the heart, but actually also in the lungs. Here you can see that the infiltration seen by CT can also be visualized by MR. And that brings me to the point that MR, and we're actually doing that in our institution, can also be used in the same session, in the same scan, to look at pulmonary interventions. Okay, so the next case I wanted to show before we get to basically the main paper is also a case reports. Now you were going to the CMR findings. This is from German side, Julian Lütgens from Bonn, and he presents a case here with COVID, and this patient had evidence for myocardial injury. And I will not go into the details, but what it showed here is what I consider, from what I have seen from colleagues from Italy, from our own admittedly small experience, but from other case series, and that is probably what you could call the best candidate for a quote-unquote typical appearance of COVID-related myocarditis. There's some pericardial effusion, and there's significant edema everywhere, basically. T1 is also increased due to edema, and then no or virtually no late enhancement. This pattern of edema, pericardial effusion, but no late enhancement seems to be way more frequent than what we usually see in viral myocarditis. So that is very important. So with that, I would go to this paper from China, and it's specifically it's from Wuhan, from the Tongji Medical College. First author is Huang, and I hope I pronounced that correctly. And it's from the Department of Radiology. So what they did, they collected patients with COVID and did a retrospective analysis of the findings they obtained with MR. So patients' inclusion criteria were previously confirmed SARS-CoV as coronavirus infection. They had to be recovered from that, so it's recovered COVID, but they were symptomatic, like with chest pain, palpitations, and chest distress. So patients had COVID, they were recovered, but had cardiac symptoms. So those are the patients of this paper. Excluded if they had a previous history of coronary artery disease or myocarditis. Of course, generally the MR contraindications, and then if the image quality was not sufficient. I couldn't find out information on how many patients that happened, but anyhow. And then they compared this to healthy controls, which they took from their patients. So it may not be a totally healthy control, but at least not having had COVID and no other discernible cardiovascular disease. The study was performed on a 3-Tesla scanner. And the scanning protocol is what we would call the basic myocarditis protocol. SYN is for function, T2 weighted imaging, so that's the STIR, the triple inversion recovery, late gadolinium enhancement, but then also T1 and T2 mapping. So this is the protocol many centers are now using compared with the original Lake Louise criteria. It does not include the early enhancement, but adds the T1 and T2 mapping. So otherwise, the technology was pretty standard, so I will not go into detail here. They had a hematocrit so that they could also measure extracellular volume. So they had an analysis of 2 experienced radiologists, and then a third one that also very experienced, who read these cases. The parameters were the myocardial edema ratio, so the signal intensity ratio between myocardium and a skeletal muscle, with a cutoff of 2.0. Then late gadolinium enhancement, and if there were, as I said, if there are discrepancies, then there was a senior observer who basically then made the call, yay or nay. And then the late gadolinium enhancement was defined as 5 standard deviations. This is something that is not entirely clear in the literature. 5 standard deviation is definitely a good standard for myocardial infarction. One may argue that for myocarditis, 5 standard deviations is tough. We know that if you use 3 standard deviations, you see more lesions that are also visually apparent, because 5 standard deviation is probably the best for a solid replacement fibrosis like in an infarct. But for a more scattered event like myocarditis, 5 standard deviations may be difficult to achieve in some of. So what this wants to say is that this was definitely a very specific approach here, where so when they saw late gadolinium enhancement, there definitely was late enhancement. Then they assessed global T1, T2, and calculated from pre and post contrast T1 the extracellular volume. They also looked at function. Standard methods for the statistical analysis. So all in all, they had 26 patients and 20 controls, age matched, so can be used for comparing that. And then the patient, they also had standard therapy, and so we do not need to, important to realize is here the median duration from onset of cardiac symptoms to CMR was 47 days. So that may be considered one of the weaknesses here. So there has been a time of at least a month in most of the patients between the onset of symptoms. So it definitely, we do not necessarily have to expect that we see all the acute inflammation, because that may have already been at least partly gone. So then they analyzed also the entire data set on a segmental basis, and what they found was, and let's maybe move to the central illustration here. So let's first here. So these are findings. I mean, we know some of that. Here, this, however, could also be considered like a mid-wall sign, which is a more non-specific sign for cardiomyopathy and advanced heart failure. The same is true for the insertion point fibrosis that we also see, that I also would consider something very similar to the mid-wall sign. I think they are even probably pathophysiologically connected, but that's for another day. And here are two examples of here the healthy person and patients with myocarditis, where we see an increase of T2 and not a lot of late enhancement, and that is important. So this is what they actually observed. That let's go back to the text. So what they observed was interesting, because as we also heard from other cases, there was a lot of edema, high T2, but only one patient had a late gadolinium enhancement without edema. Most had edema, and not many had, let's call it like that, with late gadolinium enhancement. About half of them had any late gadolinium enhancement. Now, one could argue that because the threshold was set to 5 standard deviations, maybe if you would have set it to 3, you would have identified more. But definitely late gadolinium enhancement was not the predominant finding here. And then accordingly, T1, T2, and EACVI were all increased, and that is important because especially T2 is a very good marker for edema. Now, for function, only one of the patients had an impaired left ventricular ejection fraction, so pretty normal LV function. And then they have a nice discussion where they go through all the potential aspects and potential weaknesses of that paper. So the majority of the T2 signal that is important was located in the septum, anterior, anterolateral, and inferior, and not so much in the inferolateral, where we typically see it in acute viral myocarditis. So the authors conclude that in patients with COVID, recovered COVID, there may be a sustained cardiac involvement, and that can be visualized by MR if they are symptomatic. And the MR findings are edema, especially edema, and to a lesser extent fibrosis and RV dysfunction. So what should we take away from that? And then I would welcome any comments, and I will also go to the chat and go to the questions and comments. So from this paper, I think what we can take away, as the authors conclude, there is COVID, and we also know that from findings in the lungs, COVID does not go away that easily, not in the world as a disease, but also not in patients that easily. So there is increasing evidence that patients may have persisting injury. And the two organs that are affected by COVID-19 especially are the lungs and the heart. And in the heart, as I showed before with a case report from Julian Lütgens, but also the previous case from Inciardi and others in Italy, and also case series. And Julian I was on the phone with him. He has collected in the meantime 4 other cases, all the same, severe edema, some pericardial effusion, and low late enhancement. So my takeaway would be that this paper indicates that some of what we see acutely with edema may persist and may lead to symptomatic patients even as long as a month or later after COVID. So we will need more data to understand what this means. But it could mean that, there is a prolonged recovery phase, and it could mean that ACE2 as a modulator of inflammation, but also as a regulator for vascular permeability, may be damaged for longer, and that we deal with a disease that predominantly leads to edema. Now, if you have a lot of edema in the heart, what happens? The heart gets thicker, that's what many see, gets stiff, so the filling is impaired, which means the cardiac stroke volume, the ventricular stroke volume decreases. That means the cardiac output drops. So patients get into heart failure right away, and the ejection fraction may be totally normal. And that's why there's also a limitation for echo. The quantification of stroke volume is a challenge for echo. And sometimes an echo may say it's a normal ejection fraction, but patients may be in critical heart failure. Okay, so we're already close to a half hour, so let me just jump to the chat room. But first, I want to ask Dr. Huang, would you want to comment on the paper, on the work, or any of the other experience you could share with us from Wuhan? I think you have to unmute yourself if you because I see you're there, but you're still muted. Okay, so while that happens, I go through the case. So Warren, hi, thanks for joining. So you're saying rightfully, it's a bit strange that echo was ranked in the first paper as superior to CMR for suspected pericarditis. I totally agree. With echo, you can identify pericardial effusion, but CMR can do that, but also can look at late enhancement as another marker for pericarditis. And then also I mentioned that echo is easier and less expensive, and that's why I think it's a great technique for the emergency room to quickly look. But it's not the method to have definitive answers, and you say it's CMR is far more sensitive for loculated effusions, yes, and allow you to see inflammation, yes. And then there's also the question, maybe to Dr. Huang, if that would technically work, what cardiac symptoms mean, but I guess it was what was in that short list, mainly chest pain and shortness of breath. That was not otherwise explained. And then there's a remark from Golnaz Hushmand. Feel free to speak up, otherwise I'm happy to read it. So he's writing, I saw at least 3 patients with edema with no significant late enhancement. I also had a patient 2 months after recovery with edema and subtle mild inferior fibrosis. Thank you very much. So if you would send me an email, we'll trying to collect these cases. There's also the SCMR registry, so it will be important, but what you're saying definitely confirms what people have found so far, that COVID-19 related myocarditis, apparently it looks like it is a disease that comes with edema, pericardial effusion, probably loss of fluid into the third space, and without a lot of late enhancement. So for those of you who do cardiac MR, please make sure that you have good T2 maps or good T2 weighted imaging. If you don't have the T2 maps, because if you only look at late enhancement, you may miss it here. And late enhancement anyways is not a marker for inflammation, it's just a marker for inflammatory injury. And if you have just edema, it's still injury and can even lead to global diffuse fibrosis, but it cannot be identified by late gadolinium enhancement. There's a comment from Niraya Yedlapati. Late gadolinium enhancement could be non-specific from heart failure, pulmonary hypertension, etc. Should be accompanied by T2 enhancement, call it myocarditis. Yes, that's true. Especially, I think, around the RV insertion points and the midwall signs. So those are chronic changes that happen because of the increased stress in these areas. And that is non-specific, can be in hypertrophic cardiomyopathy, in pulmonary hypertension, in chronic heart failure. I've seen that also after a cardiogenic shock with full recovery. So, and then there's another interesting remark, I'm thankful for that, from Alejandro Trevino. Are these findings similar to Takotsubo? I think that is a very good point. My personal opinion is that we deal with myocardial edema more often than we think. Takotsubo is definitely the end of a spectrum of severe edema, in that case also with severe wall motion abnormality that can be triggered by stressful events, but also by neurological acute clinical events. But I think there's not only that end of the spectrum, but I think on another side of the spectrum, we have, for example, diseases like HFpEF. HFpEF, we have ourselves shown that about half of patients with HFpEF, if you take them off the street and put them into a scanner, have an increased T2 time. So I think what happens, especially elderly women in Takotsubo, also happens to elderly women with hypertension. They have edema. Edema stiffens the heart and can lead to heart failure, and then it would appear as heart failure with preserved ejection fraction. So yes, I think there is the massive inflammatory response that we also know from Takotsubo, where it's triggered by catecholamines. That is also what we can observe here. So then one question, how many slices per plane are you averaging your T2 and T1 maps? Are you mapping all 3 planes? So that's a good question. We're doing typically 2 slices because the very basal one has a problem with the outflow tract, and the apical ones have a lot of partial volume effects. But we also have started working with long axis views because you actually see more of the myocardium. So the more you get, the better. But my recommendation would be 3 long axis views plus 2 short axis views. And if you don't have the time, the minimum would be 2 short axis views. Okay, I feel bad because we're already 4 minutes over time. And my promise is to not steal too much of people's time and make it efficient. So with that said, any comments, remarks, questions? If not, I want to cordially thank you for your attention. I want to point to and unfortunately I don't have the slide now here, to the next JCMR Journal Club. Please visit the website, the SCMR website. There's basically every Wednesday, you have every Wednesday of the month, you have one of the journal clubs, I think, except for one. And the next JCMR Journal Club, I will have to look that up here, is on June 10. So it is in 1 week at 11 o'clock. And Scott Flam will be the moderator and will present the article Cardiovascular Magnetic Resonance Native T2 and T2 star Quantitative Values for Cardiomyopathies and Heart Transplantations, a systematic review and meta-analysis. So join the Journal Club next week, 11 o'clock, same time, Wednesday. Scott Flam will moderate that session. And with that, I want to thank you very much and hope you have a good day and stay safe until sometime soon. Bye-bye.